So our next talk is from a hidden hero of our program. Um, and all of you know from what Anne presented at the outset, that primary melanoma tissue banking is part of the mission that Val Guild, Susan Steele, others really embraced 15 years ago when we began to try to drum up support for this. But tissue is the issue, because if we don't have the tissue, we can't possibly understand the mechanisms that underlie all of these phenomena that you've heard about from Darcy, and you'll hear about ever more from Jana and Diwakar and Brittany going forward. So tissue isn't quite as simple as it would sound, because it's very hard to get these samples. It's hard to get consent from people in advance to be able to collect the samples. And we have a huge resource here in our data acquisition and data entry team, led by Mary Horak, who's actually been a part of the melanoma program back 25 years ago, I think.
Not quite.
Not quite, almost 20. But basically, we'll speak to you today about the nuances, the subtleties, the challenges of tissue banking, which is what allows us to understand how the things that work, why the things that don't work, and the ways that we can abrogate resistance to the treatment failures that we've actually encountered. Mary, thank you for coming.
Good morning, everyone. Thank you. Thank you, Dr. Kirkwood. So I work in our Clinical Research Services department. We are the department that provides the infrastructure here at Hillman to conduct all of our clinical research trials. And my goal is to talk to you about how we use tissue and how that translates from the benchtop research lab into new treatments for our patients. So we'll start with the basics. What is tissue? So a tissue is a layer of cells or a group of cells working together to perform a function. So Darcy just explained to us the skin being the largest organ. So the skin functions to protect us. Our blood functions to send oxygen through the body. So that's what we're talking about when we say tissue. So in research, we're referring to more than just tumor tissues. We are referring to that, yes, but then also things such as blood, urine, stool, other organ tissue, normal organ tissue. So normal tissue is just as important to look at to see what it's doing versus our tumor tissue. And these samples are often referred to as biospecimens or correlative samples. So we use tissue clinically to make a diagnosis for cancer. So we want to know what kind of cancer you have so we can treat it appropriately and give you the best treatment option for that cancer. And we use tissues to find ways to prevent, diagnose, and treat cancer. And this tissue research takes a long time. We need a lot of samples from a lot of different patients. So we need to involve a lot of institutions outside of ourselves to do this work. And it takes a long time for this research for those results to be known, to really know what we're seeing, what trends we're seeing. So the tissue for future use is often stored in a tissue bank. And a tissue bank is a facility that organizes these tissues. They annotate them, they collect them, they store them, and distribute that to researchers so that they can do basic and translational science. So again, taking what we learn from tissue, translating that to our patients. And by studying these tissues in the laboratory, we can discover different biomarkers, molecules to learn how cells work and how they might respond to treatment. And our basic science also begins with this tissue, this research, which leads to these new treatments. So our laboratory technicians are really the ones who process these tissue samples, make sure they are stored in a way that's viable. So when our researchers want to actually analyze these tissues to answer their questions, that tissue is adequate. So here at Hillman, we are very fortunate to have a few different melanoma tissue banks. Two really important ones are our 96099 tissue bank, which has been collecting samples at our UPMC Hillman location since 1997. This predates some of the age of some of our staff in our department now. So it's been a long time we've been collecting these samples. And then with 1906, 99, we typically collect blood and tumor samples, but we can also collect other types of tissues as well. And then 16055 is a tissue bank open here, but also open across the United States with several different sites, as well as in Australia. And 16055 is really important because this is supported through AIM and Melanoma. So we really appreciate their support. This is the tissue bank that Anne was referring to this morning when she opened. So with this tissue, we are able to collectively gather samples from patients across the United States, across the world, really, to use this information in projects to learn more about melanoma. So how do we use this tissue? Again, we're really trying to determine how well patients will respond to treatments and how the treatments really work. And we can develop a theory and then use this tissue to test that theory to see if we are onto something. And research with molecular mutations really has resulted in treatments that we can target towards those mutations to give you that personalized medicine. So Dominic started this morning talking about BRAF. So BRAF is a common melanoma mutation, as well as NRAS, c-KIT. So again, we target these to give you the best treatment for your cancer. So we collect this tissue. What do we do with it? Why do we analyze it? One way is to determine a response to treatment. So these slides are examples of what we call H&E staining. And on the far left, we can see normal tissue. So we see what tissue should look like. In the middle and the right shows a pathological non-response and a pathologic complete response. So this is work from Dr. Najjar, and with a pathological non-response, this tumor did not respond to tissue to a treatment, whereas the pathological complete response, that tumor did respond to a treatment. So this gives us a lot of information, but it doesn't give us the whole picture. So we don't know why the non-responder didn't respond, and we don't know why necessarily the complete response, what killed those cancer cells. So we have to delve a little bit deeper and look at more of the tissue to understand really what's going on. And with that, we can analyze tissue to assess the tumor microenvironment. And the tumor microenvironment is the cells and the tissue surrounding the tumor, which can work to help feed that tumor. The tumor can affect the microenvironment, but then the microenvironment can also affect the tumor. And we can determine response based on the microenvironment as well. So there's many different ways we can look at this microenvironment. Each technique gives you a different perspective and a different way to look at that. But we like to look at it collectively as a whole, because if we're looking at just, for example, CD8 here, you're not getting that big picture. So this is called fluorescent microscopy. And when we combine it together, we see that big picture, and we can see something like the blue cells are the active tumor, and we know what those tumors are doing. To kind of further look at that microenvironment, we can also look at biomarkers. So when we're looking at biomarkers collectively, and we can see trends over several samples, we know we can target that to try to develop therapies to treat those tumor types and develop those personalized therapies. So here at Hillman, going back to the 96099 tissue bank, we have several projects ongoing at any time, but two I wanted to highlight is a project with patients with multiple melanoma diagnoses. So the goal of this is to look at those patients to see if there is some sort of inherited genetic risk factor that's causing those patients to develop another melanoma. And this is a partnership between us and Cleveland Clinic. So again, using another center so we can have a wider assortment of samples and a larger patient population, hopefully get this research done a little quicker. The second project is looking at genetic mutations in cutaneous melanoma patients and looking at the implications for recurrence. So these are patients who have not recurred, and we're trying to investigate genetic mutations to see what might predict potentially which patients will recur and at what time frame. So will these patients recur in 2 years, in 5 years, greater than 10 years? As an example of a project that's been completed, We had some researchers looking at acromelanoma specifically, because we know acromelanoma doesn't respond in the same way as the other cutaneous melanomas when we give them checkpoint inhibitor treatment. So in this, they identified a unique set of pathways associated with that resistance. And from that information, again, we can develop treatments to focus on that pathway to treat these patients. So this is an example in the images at the bottom. We have some H&E staining on the top. So you see the dark purple is tumor tissue. And then again, that fluorescent microscopy where we can see the different tumors, like the different cells lighting up based on the imaging. So this tissue research, again, really drives and lays the foundation for developing clinical trials where we're actually treating patients to see if treatments are effective. So clinical trials are written by our researchers along with biostatisticians who help ensure that we write these protocols in a way that we can actually measure the results and determine that they actually mean something. It's not just random chance, but there's a statistical component to it that we know that this actually means something. So we use something called objectives and endpoints to kind of frame the research question so we know what kind of data we need to collect to answer that. So often for clinical trials, the endpoints are safety and effective. So not all trials have these endpoints, but these are common ones. So safety, we're looking at adverse events. So what kind of side effects are our patients experiencing? Efficacy is the disease response. So how are our patients' tumors responding to these treatments? Are they getting better? Are they staying the same? Are they getting worse? All of that's important information for us to learn. So when we're collecting data, whether we're looking at tissue banking trials or clinical trials for treatment, we have to collect the clinical characteristics of our patients. So we need to know their information such as gender, racial, ethnicity group, their age, their prior treatments, their diagnosis date, what type of melanoma they have, because we have to correlate this with our results so that we know that how everything kind of comes together so we know which treatments will benefit which patients the most. So one of the things that's really important is prior cancer treatments, because we need to know if a patient had a prior treatment, maybe that prior treatment is causing this new treatment to them to respond better. So when we're looking specifically at tissue banks, we need to know what tissue is there, what samples do we have, so that when a researcher has an idea for a project, we know that these samples are available to conduct that research. So the most important thing is the sample identification. Where is it? What is it? Is it blood? Is it tissue? Is it tumor tissue? Is it plasma cells? All of that kind of thing. When it was collected, so how old it is, when it correlated to the patient's diagnosis. So all of that's really important for us when we're building these tissue banks. So we need to know what we have. Also, for our samples, if it is a tumor tissue, we need to know those pathologic details. So is it cutaneous melanoma? What kind specifically? Is it acromelanoma? Is it ocular melanoma, mucosal? How thick it was? All of those kind of characteristics we need to know and annotate. So when, again, a researcher wants to conduct a study, they know exactly what they're getting. So if we go back to that April study that we conducted here, when they were ready to perform that study, the tissue bank had to provide them acromelanoma samples. So how it comes together. For shifting and looking at clinical trials, again, when we're looking at things such as safety or efficacy, when we're looking at safety, we're looking at those side effects. So like Dominic talked about with the BRAF inhibitors, what kind of side effects do patients have? So we record every side effect a patient complains of because we need to know, is that really related to the treatment or is it from some other cause? So we have a standard system where we grade these based on severity. And we have a tool that we use that makes sure that we are using the same methodology across all patients. And then our investigators, so our research trained physicians or physician assistants, are looking at these side effects and determining, are they related to the treatment or some other cause? So if the patient has weight loss, did they lose weight because they were so nauseous they couldn't eat, or did they lose weight because they went on a diet? So this is the kind of information that we're teasing out to determine the safety of our drugs. When we're looking at efficacy and how the disease is responding, we look at baseline prior to the treatment and then the subsequent scans at whatever cadence is required for that trial. So here we have a baseline scan on the left, which is a CT from before the treatment started. And then we have a CT 3 months into treatment, and we translate that information from the scans into a format that we can reproduce and we can analyze. So this is something we call in clinical research our tumor measurement form. And so on the left, you can see, hopefully if it's not too small, that this patient's tumor burden at baseline was 3.37 centimeters. And then after 3 months of treatment, we rescan them and their disease reduced down to 2.3 centimeters. So that's a 32% reduction. So that's really good. We really like to see that. And then we categorize that in a response. In this case, it's called partial response. So we have these, again, different criteria there. We can categorize these responses using the same methodology across all patients, whether it's here or in Cleveland or California, we all are doing it the same way. So our responses are categorized in complete response, so all that disease has gone away. Partial response, where the disease has reduced by more than 30%. We have progression, where the disease has increased by 20% from its smallest volume. Or if it doesn't meet any of those, it's called stable disease. And stable disease is still a good thing. So that's how we're collecting this data. So once we have all of this, we have to organize it in a way that we know what we have and we can actually analyze it. So we enter it into a database. Here, all of our data is manually entered by someone. And there's different databases. They capture the same type of information. They're set up the same similar ways. Medidata Rave is one we use commonly. Inform is one, and then RedCap is what this screenshot is. And that's the database we use here at UPMC for our trials written by our physicians. And the information we're collecting is that adverse events, the tumor assessments, but also those clinical characteristics. So the patient's diagnosis states, their prior treatments, all of that information we're entering into the database. So while the main objective of most of these trials are commonly safety and efficacy, we are looking at tissue a lot of times in secondary objectives. So these are used to determine how the treatment is changing the tumor, or how the body is reacting to it, or how it's changing the body's immune response. So the goal of all of this tissue research is to forward science and develop future treatments and treatments that actually work better. So how this all comes together is all the data that we collect is pulled together. It's any, whether it's clinical trial or for tissue banking, we correlate those clinical, the clinical data with those results. We send it to our biostatisticians. They're the ones who conduct the analysis, and they will group patients differently based on, again, the objective. So they're looking at gender, age, prior treatments. So do women respond differently than men? Does an older population respond differently than a younger population? And then also tissue results. So grouping them by molecular diagnosis or molecular mutation, so the BRAF patients versus non-BRAF mutated patients. So all of this resulting, it takes a long time to collect all the data for clinical trials, and once the biostatistician reviews this, completes the report along with the investigators, we make that determination of how well the treatment actually worked. So with that, we can use that information to design new trials to kind of change the course of what we want to do with that treatment agent, or we can submit it to the FDA for approval. So the FDA makes sure that the data is clean, that it is accurate, and that it is a safe and effective treatment. So they thoroughly review all of this information. And then ultimately, we get drug approval. So the work that we do here in Hillman absolutely and directly contributes to the new treatments for our patients. So as Dr. Kirkwood mentioned, when we began, we had 2 recent approvals, one just in February for the T-cell therapy, which was under a clinical trial 16126, and then our clinical trial 19105 is the one from October where Nivo was approved for our adjuvant patients for stage 2B and C melanoma. So hopefully I've convinced you why it is so important to give us your tissue. Contributing to your tissue We'll help move science, help advance science. You can help us find a cure, and you can take an active role in your healthcare. You can learn more about your melanoma and the treatment by giving us tissue, and your participation is always voluntary. So whatever tissue patients are willing to give us, we are so gracious for whatever they are, and it's always, always, always voluntary. So a huge thank you to all of our patients who have given us their tissue samples and who participate in our clinical trials. And without you, we would not be here. A couple references.